And now, without further ado, I'd love to introduce our speaker. Carol Yarbrough is the Business Operations Manager at the Telehealth Resource Center at the University of California, San Francisco Medical Center. She is a healthcare compliance and reimbursement specialist. She provides a unique background in legal, technology, revenue management, clinic management, and knowledge of both federal and state healthcare regulations. She provides insight on virtual services billing, reimbursement, and compliance. She works hands on with professional and hospital based professionals to review and implement these services. She also offers current procedural terminology or CPT webinars nationally to both coding and medical professionals, and is said to make the mundane fun and even manageable. So it is my great honor to hand this over to Carol to take us through the nitty gritty of billing for telebehavioral health.
Thank you very much, Nikki. And thank you everyone for coming to our webinar today. I am indeed honored to be here at the esteemed NRTRC and speaking on with the Harborview Medical Center folks, and especially about something as important as telebehavioral health, which is it's a great thing to talk about because it's not going to go away at the end of this calendar year. So I don't feel guilty or bad about telling you about things that may or may not happen. And during the disclosure, when Nikki mentioned things may change after the date of this webinar, it may change in the hour after this webinar. Certainly, we got plenty of Friday afternoon surprises in the last 3 or 4 years as well from the feds. So, okay, so we do have learning objectives for today. You're going to learn where to locate that pesky Medicare list of telehealth services and its genesis, which is an important thing. Understand why CPT modifiers should match the modality of the service. Well, we know that's an easy one. We want to get paid, and that's why we should match it, but there's some more nuances. And then the outlook for continued reimbursement and anything new for behavioral health introduced in the 2025 proposed Medicare physician fee schedule. So the Medicare list of telehealth services. Now, if you're intimately aware of this list, as many of you probably are, and as aware as I am, this will be news for you because I just finally read, yes, the Social Security Act, Section 1834M, just this last year. And the reason why I did so is I was really concerned about, okay, we're all quoting this all the time. I've never really read it, and I should. And it brought home a lot of reality to me in the fact that everything that we say or do came from this act, and it's still influencing what we're doing today. So this was from 2001 when it was implemented. And it does set out that these are telecommunication services to an eligible telehealth individual enrolled under this Part B, someone getting Social Security, which is Medicare age. And we're not, the physician or practitioner is not at the same location as the beneficiary. There it is, right there in the act. And it's just a couple of paragraphs. And then it does talk about payment parity because everyone's always concerned about, well, are we going to get paid the same? Are they going to pay? So it does say in that section that the distance site, you're going to get paid the amount equal to the amount had you done the service in person. So, or without the use of a telecommunication system. So, notwithstanding what's going to be happening in 2025, but certainly people did not understand that for a facility provider, a hospital outpatient department provider, as a pro fee provider, you would only get paid the physician facility fee reimbursement, which is less than the non-facility fee reimbursement. because there's a facility fee associated with working in a hospital outpatient department. So here we go. There's payment parity right there in the Social Security Act. I know, mind blown. Mine certainly was, and I really should have read it 10 years ago when I started doing this. Okay, and it does specify that the originating site should receive a payment. It started off at $20 in 2001. It specifies that the home is not an originating site. I know that's going to change. That's changing for behavioral health, or it has changed. But this is where this whole thing came from, that you cannot see patients in their homes. Home is not an originating site. They're not going to get the $20 to, I guess in the year 2000 or 2001, their Cray computer that would support a video interface for a telecommunications health encounter. That really wouldn't have paid for it. This year, we're up to $29. So let's see, 23 years later. Not bad, not great. So that's where that whole payment parity thing came from. The whole thing that home was not an originating site. And then this also specified which types of services would be paid. And this is the genesis of the list. It specifies these codes. Of course, we know these are no longer paid by Medicare. 99241, these are the outpatient consult codes. 99275, which was I think an emergency department consult code back in the day when I first started coding, maybe in 2005. We know that 99201 is no longer in existence, but certainly in the year 2000, it was. And so these are all E&M encounters, evaluation and management. And here we have 3 whole behavioral health codes. And then it says any additional services specified by the secretary, and that there would be a yearly update. Well, there is a way that people can ask that codes be added to the Medicare telehealth services list, or the list as we'll call it, kind of like the JCO is no longer called JCO, it's the Joint Commission. This will be the list. There is that yearly addition of codes to the list. And what's changed in the last several years is that CMS has decided to put things there provisionally, check them out, see how they work, or on a permanent basis. So this is where the list came from, right there in the act. Who knew? Not me in May of 2024. Now I know. Okay, so July 1st in the year 2000, there were a total of 29 CPT codes. As of January 1st of this year, we had a total of 268 CPT codes. Permanent codes as of January 1st, 112 permanent codes, and that includes the 99202 through 99205, et cetera. And then we have 156 provisional codes that we now know that through the proposed 2025 Medicare physician fee schedule, they are proposing to leave on there through the end of 2025. And they've added some new codes. But, you know, it is pretty amazing when you think about all of the CPT codes that exist in the AMA's CPT code book. It's over 11,000. And during the public health emergency, we probably used 100 of the codes when you think about all the E&M encounters when we were in lockdown, and that kept healthcare rolling. But what is that, like not even 1% of the total? So I guess don't discount the value of talking for a medical encounter. Okay, so to tie back to the learning objective, this yearly update set out in the Social Security Act is published usually after the final version of the Medicare physician fee schedule is announced. And so this was updated November 13th, 2023. So it was probably the day or the day after the MPFS was published in the Federal Register. And, you click on this link, download a zip file, open up the zip file, and it's an Excel spreadsheet. So that's good to know. And then also it has the Q3014, which is the originating site facility fee. I don't know why they published this on there into such great detail, but it goes all the way back to the start of Q3014. I guess to show that we've got an additional $10 over the last 25 years. So anyway, here's the URL. And what's important about the list, if it is not on the list, it is not a telehealth service, according to Medicare. Now, I know that there are appendices at the back of the AMA CPT book, Appendix P and T, perhaps, I think it's T, where they have audio only and telehealth allowable CPT codes that the AMA has deemed acceptable. There are more codes on the Medicare list. So anyway, this is the point of that whole discussion is if it's not on the list, it's not telehealth. I don't know. I always think think of a saying like, if it's not such and such, it's not, you ain't nothing, you ain't bad, you ain't nothing, you're not on the list, you ain't telehealth. Okay, call back to Michael Jackson. But if it's not on the list, it's not going to be allowed to be billed with a place of service O2, which is a facility-based telehealth encounter, or place of service 10, which is the home. So a couple of things to note about the list. Chris Corwin created this list, and if you go into properties of the Excel you download, his name is there. So I thanked him for it. And he said, oh, I can't believe my name is stuck to that. But he kindly put in a filter for you, so you can filter by a HCPCS code, or by, you want to type in maybe PSYTX or any code that is 30 minutes, click on your filter, type in the number 30, and everything's going to come back that's 30 minutes. You can also filter for whether or not audio only is eligible or applicable. So yes or no, very simple. And then here again, provisional versus permanent. So provisionally, we have, well, of course, all right, let's not talk about radiation treatment management ×5. Okay, let's not talk about that one. But health, oh, here are these wellness coaching codes that have no RVU value, but they added them provisionally this year to see who would use them if they were allowed via audio or via telehealth. I don't know. You still don't get paid. I don't imagine many people did it. What this may have done is allow the Medicare Advantage people, the insurance payers, to start thinking, well, maybe we should reimburse for it since it's on the Medicare list. Who knows? Who knows? But it is provisional, and they wanted to see if anyone was going to use it. Those are the new classification of provider of a wellness coach. These are people that now can get NPIs. They're not eligible telehealth providers. I don't know. I'm confused by that one. I've just backed myself into a corner on it. Okay, so we're going to talk about modifiers now in place of service. So you know where the list is, you know where it came from. And then I did say things like place of service, O2, 10, originating site. All of this ties in currently and in the future with delivering behavioral health services. So these are common modifiers, I think, for behavioral health. I've been doing some psych coding of late. So I kind of think I'm a little bit of an expert at this point. No, I just know enough to know that I need to research every single thing that I look at in a chart. Anyway, so modifier 25. This is a modifier that always goes on the evaluation and management code. For instance, you have I do have an example coming. So this only ever goes on the E&M, doesn't go on anything else, doesn't go on a procedure code, another site code, nothing. It goes on the E&M because it's identifying the E&M code as the service that is separate from the procedure or service that was given on that same day. So you're identifying the E&M code as the separate service, not the injection or the, I don't know, venipuncture. Like gladly, if you leave off that 25, payers will pay for a venipuncture and not the E&M code. Okay, so going through our numbers, 93, synchronous telemedicine service. Now they're calling it a telemedicine service. It's on the list. Rendered via telephone or other real-time interactive audio only. I can turn off my camera and I can do this audio only. I'm using a telecommunication system and we're interacting. I mean, I'm reading your chats when I can. So this would be the type of service they're referring to. The FQ modifier, and I've heard different things about it. Like only used for a Medicare service, not for da da da, only used for behavioral health. I can't tell you one way or another. You have to try it out, see what your denials come back as, and adjust your claim management accordingly. But anyway, I digress. It's a service furnished using audio only communication technology. So it's not Zoom, it's not WebEx, it's not whatever, it's using a telephone. Okay. Synchronous telemedicine service. Again, we have that telemedicine word via real-time audio and video. And that's what the Social Security Act said a Medicare service is, using real-time audio and video. So all this language is coming out of that Social Security Act, the 2 paragraphs. It's amazing to me. Anyway, 95 is the designated modifier. Now that would go on your CPT code. You're doing an evaluation and management service. You're a psychiatrist, so you're an MD. You put a 99214 together with a 95 modifier. And then, probably with that level 4, you're doing something with meds based on risk. So the thing that I'm not sure about what's going to change is whether or not they're going to require 95. Recall, prior to the public health emergency, Medicare said, well, if you're using O2, you don't need the 95, so leave it off. Don't use GT, leave it off. It's redundant. We're not going to even pay you if you put it on there. So we all stopped using it. And then the PHE hit, and they were like, you know what, put 95 on there, because there were some other payment caveats they were using. So GT, it's the same thing, interactive audio video. This was the first code that Medicare had. Then the AMA came up with 95, kind of sort of like how CMS had FQ, and then AMA came up with 93. So GT, they only want it on institutional claims. So an institutional claim is the UB04, not the CMS 1500, because that's how you bill at a critical access hospital, is only an institutional claim. CAH method 2 providers. Okay. Okay, and FR, this is important for teaching institutions such as University of Washington, a supervising practitioner, the attending, the billing provider. is present through two-way audio and video communication technology, meaning they're the ones that can bill for the service. So a resident is maybe sitting in their home. A patient is sitting in their home. The attending is sitting in their office. They're in Seattle. The resident is not with the patient. The resident is not with the attending. It does say two-way audio and video, but that's the modality. It's actually three sites that will lend into being able to bill FR, or requiring you to append FR and bill for a teaching situation encounter. Okay, so here's where I pulled this out of the 2025 proposed rule. So it does say for audio only, use a modifier designated by CMS, blah, blah, blah. And then it says, oh, you can use FQ or 93 since it means the same thing anyway. Okay, well, here it says only use FQ for RHCs and FQs. So I guess that's on an institutional claim, right? Billing. So you'd use an FQ modifier, like for the CAH using GT. And then, but then it says you can use whatever. So hopefully they'll clarify that in the rule, because I get so many questions about this, and I end up saying put both of those on the CPT code and put it on your invoice. If anyone wants to put in the chat, if they have something they can share about whether or not you've been getting denied, or if a commercial payer says we want FQ on behavioral health, but we want 93 on everything else, that would be helpful for the other attendees and for me, so I can share the love. Okay. This is your place of service, folks. Behavioral health is the only service that will retain the ability to see patients in their homes in 2025 and get paid the same as you would as if you were practicing from place of service 11, the non-facility. So let's harken back to payment parity. A provider at a facility would only get the professional fee, because usually the facility bills a facility fee. At a non-facility, you get a global payment. So and the MLN Matters came out clarifying that that we're going to get the professional fee non-facility rate. And this has been put in regulations. It's in the online manual now. And an announcement came out. Here's the URL. It came out effective July 8th, that it's now in the manual. It's not just hearsay or in a Federal Register rule. That they're always going to pay that global fee. So the question I have about that, because I question everything, for behavioral health providers who see patients from their billing group is at a facility, their medical group at a facility, I guess they're going to get the global with no affiliated or associated facility fee. Now, if you're a reader of OPPS, as I am, they are proposing that G0463 be considered for payment when providers who are at a facility location, a SNF, hospital, academic medical center, that they get reimbursed something on the facility side, the G0463, which is the facility equivalent of the average price of 99202 to 99215, because that G0463 is the facility equivalent of that. And it was not paid for this whole last year when providers have been seeing patients from facilities. So they understand it's not fair. CMS, anytime I say they, I'm referring to CMS. They understand it's not quite fair because there are costs that go into registering the patient, telecommunications, paying your Zoom license, paying your whatever license, Doximity. So they are taking under consideration, perhaps, like during the PHE, we could build that with a PN modifier. We got paid $40. I mean, if you got $100 for the facility fee, they paid 40%. So you can. So maybe that will come into play. That would be great. It wouldn't be a total loss. If our providers that are located in cities were providing rural health from this distant site to an originating site in a rural area, in a physician shortage area, non-city. Place of service too. Everything that's not the home. It's a facility. So this is where I was kind of waxing poetic. Patients not at home, it doesn't mean they're at a hotel, but they are at a facility like an RHC, or they are at the SNF, or they are at another office in a health system, and behavioral health person is then interacting with them via telecommunications. So this would be your place of service O2. So the places of service are dictating the payment, which is unusual. I mean, maybe not, well, okay, there are 3 places service codes that dictate payment right now: 11, 19, and 22. 11 is the non-facility, 19 and 22 are the physician-based department and hospital outpatient department. This is even parsing it further. When they developed place of service 10, I think it was in anticipation of providing more mental health care in patients' homes. And that code even came out during the PHE 2021. There's been a little bit of confusion about using it. So anyway, all right, first example, psychiatrist and patient meet. They are synchronous. Provider prescribes an RX, always my go-to example for level 4, which is meaning that you're prescribing something that is not over the counter, and also administers psychotherapy via telehealth. So 99214 with a 25 modifier, 90833. I'm anticipating no modifier, no 95, place of service 10. And I kind of cheated on this one a little because 99214 is not allowable via audio only on the Medicare telehealth list. They are considering changing it for next year. They are considering the fact that maybe the patient does not want to be on screen. They are considering the broadband is not wide enough for video to function accurately or enough for a real synchronous conversation to happen. So it could change. But I cheated and said, this is via telehealth. It's not audio, because I don't quite know what to put on there yet. So these are things that could change. I know that's the last half of my presentation, but I like to mix it up just to keep everything kind of confusing. Here's the example of FR. Teaching psychiatrist joins resident and patient in their encounter. 3 nodes. Provider prescribes RX, hence the 99214 25 modifier with the FR, teaching physician interaction. They attest to the residents' prior interaction and perhaps documentation of the evaluation and management encounter that preceded them joining the call, and the psychotherapy provided by that resident, FR modifier, place of service 10. Now, would this also require a GC modifier for ACGME programs? Would the FR supersede the GC? These are things we're going to have to ask our Medicare administrative contractors. I did see somebody from New Jersey on here, so I can't say let's all ask Neridian today and see what they say. I guess you'd have to ask NGS about that. So I don't know. I'm thinking FR is indicative enough that it is a teaching situation, and you don't need a GC modifier on there either to indicate that it was a teaching encounter. Okay. Another example. Clinician and patient meet for psychotherapy via audio only. 90845 93 modifier, place of service 10. Now, the reason why there is a modifier, even though place of service 10 is already telling us it's telehealth in a patient's home, 93 is letting CMS or whomever know that it was audio only. And hopefully in that documentation, you have documented why it can only take place via audio only. Maybe some templates, no broadband, internet was out, patient felt shy today, they didn't wash their hair. I washed my hair. That's why I was late coming on to the pre-meeting before this webinar. Okay. So what's the difference? What is the difference? Why does it matter? Not only we want to tell CMS, this is where the patient is. This is how it took place. This is the thought process behind what happened. Audio only, telehealth, at home, in a facility. There are costs differences associated with where you're practicing. So currently you see a patient in person, 90834, 45 minutes. The facility reimbursement on that is going to be $90.19. There is no associated facility fee with that. The non-facility reimbursement, well, I'm not sure. Not G0463 is supposed to be associated with an evaluation and management service. There might be another fee, probably indicated on the UBO for using Rev Code 250. Okay, so, and indicating 90834 as well. And you'll get the TC portion of that. So the non-facility reimbursement is $13 more. So you can see here you got your work RVUs, and then the non-facility practice expense RVUs. You see the non-facility practice expense is higher than the facility practice expense because they're assuming, well, the provider is paying into whatever their medical group, or the medical group is paying a contracted rate to be allowed to practice at the facility. So it's costing them something. Malpractice RVUs are the same for both, but you can see this is why this is different. The practice expense RVUs are higher at a non-facility because they're paying for everything. They're not sharing that load with them, with the ambulatory or facility building. The people that administer the clinic, the people that are at the front desk, those are all facility employees. Okay, so that's the difference. We're at 1140. I'll speed up a little bit here. Okay, so This is what's happening now. To quote Flip Wilson, this is the church of what's happening now. So, as authorized by the CAA, there was a permanent change made back in 2022. Fantastic. Marriage family therapists, mental health counselors are now permanently eligible telehealth providers. If you go back to the Social Security Act, there is a list of eligible providers that do not include these two types of providers. Everything else is there: nurse practitioner, physician assistant, nurse midwife, all of those people. Maybe they're going to amend the Social Security Act, but maybe simply having it be codified into statutory law by this act, they don't need to do that. But it would help us out, wouldn't it, to have it all in one place? So anyway, Medicare Part B, these folks get 75% of what a clinical psychologist is paid. It's right here on this webpage, tells everything you need to know, which is a great resource. If you haven't started billing these folks yet, or if you're one of those folks, how to enroll with Medicare, where do I bill, how do I fill out the CMS 1500, It's all right there on that page. Very great resource. I'm so approving of the federal government right now. I don't know. I'm kind of feeling hopeful. Whoa, I just took a whole left turn there, didn't I? Let me go back here. Okay. Oh, this is what I want to talk about. This is what happened, not just this year, but the year before. But we have pricing that we can get now from our max for the cognitive behavioral therapy, 98978. If you call them and say, how much are you guys paying? Because on the fee schedule, it says priced by the MAC. Okay. So you call your MAC and it's pretty much exactly what they're paying for the 98977, which is respiratory monitoring. So RTM, I couldn't tell you who's been billing it yet or not. I have, well, actually, I could tell you. I could tell you who's been billing it for CBT, but then I'd have to kill you all. No, I'm kidding. It is being built. Some of the problems are that maybe the claim logic doesn't recognize an LCSW as someone who can provide cognitive behavioral therapy or monitor it via this billing the 98980. LCSWs are on the very first eligible telehealth list. This isn't telehealth though. This is communication technology based service. So if you're going to provide this service, just watch those denials. Make sure you have staff that knows how to take things through the appeal process. But I think they're just used to people billing these codes if they're physical therapists for musculoskeletal, 98976, or respiratory therapist or an occupational therapist, 98977. All of a sudden they see an LCSW show up on a CMS 1500 with this code. They're like, wait, this is RTM. What? Claim logic needs to catch up with the changes. So, we do our best. We're right there with them. We're going to help them pay their claims correctly. So anyway, it's a whole different thing. I could take an hour talking about RTM. So I'll just move on. If anyone has questions, please contact the team with this webinar series and they'll get the information to me and I will respond to you then. Okay, proposed updates. What digital mental health treatment devices? We already have RTM. What's pray tell? I'll talk about it on the next slide. Also, e-consult codes for behavioral health. So cool. I love e-consults. Updates to opioid treatment programs and delay in requiring in-person visit requirements for mental health services. Yay. That's something we can all get behind. So, okay. I'm going to talk about the provisional telehealth list first, though, and then go into DHMT. Okay. So there's already these behavior management services uh, for family group, multiple family groups to everybody meet and talk about how they cope with their loved one who has dementia, their loved one who has some kind of behavior, substance use disorder. Uh, so it's a multiple family. CMS said, let's make it one better. Let's give the caregiver one-on-one individual training for behavior management. So it's giving the caregiver tools to manage how they react to the behavior they're presented with. And these are provisionally on the telehealth list for this year. Fantastic, because having a multiple family group behavior management, this wasn't on the list last year or this year. So these are great additions, and I hopefully it would help your practices quite a bit. Behavioral health strategy. So they have this whole thing. It's called the CMS Behavioral Health Strategy Initiative. And there's a website dedicated to it. Safety planning interventions. I don't, I think this is a proposed HCPCS code. If you like it, if you think it would be useful to put on a telehealth, on the Medicare telehealth list, they didn't specify whether or not they're going to do that or not. Send in a comment letter and say this would be great for the telehealth list. 20 minutes. It's got a nice, robust RVU there, 1.09. You added the practice expense, it's going to be about 1.6. It's a nice reimbursement for an important service. Another proposal, not telehealth, post-discharge telephonic. They specify it's telephone, so it's not audio visual, hence it's not telehealth. Post-discharge, emergency department for behavioral health or crisis encounter. Someone comes into the emergency department, psych gets called in for a consult, provider or the patient stabilized, they go out into the world. Now, instead of trying to figure out how can I do a video visit as an ED provider or as a behavioral health provider with a patient that maybe has a flip phone or no broadband or pay for minutes, you've got a real one-time telephone interaction to be able to follow up with them after that crisis in the emergency department. Super cool code. Okay, it's 11:48. I'm going to start jamming. Digital mental health treatment services. These are FDA cleared devices as opposed to RTM. That's an FDA defined device. So an FDA cleared means it had to have either met, it has to meet another device that was cleared already, or it has to be cleared by the FDA because you're going to treat somebody's mental health. An FDA defined device is a tongue depressor. So cognitive behavioral therapy, RTM, one would say, I don't know, software as medical device, some kind of meditation app, something like that. This is going to be treatment management as opposed to monitoring. So they did model the reimbursement. And they also said contractor pricing on the device cost. So if your application cost to your clinic service or your clinic location is going to be really hefty, You got to call Noridian and say, look, this is how much this stuff costs. Make sure you pay us enough money to cover that cost if we onboard 100 patients, something like that. So this is, I don't know, write a comment to CMS if you're a vendor and you have some kind of idea, or you think you've got some ideas about this, all these innovators at our academic medical centers. So yeah, it's a software device that is cleared, delivering a mental health treatment intervention, demonstrable positive therapeutic impact. Okay. E-consult codes. I love this. So right now, only MDs can perform an e-consult, physician to physician encounter, either written or written and verbal. They have modeled these 6 codes for providers that are not MDs. Beauty. And they're going to price them accordingly, probably. But it's pretty cool. And here are the definitions of them. So just know that it says, interprofessional, telephone, internet, blah, 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 blah. Consultative discussion and review. They want you to write something down and also speak to the requesting provider. Medical consultative discussion. They're very specific. There should be 2 codes that are written only. Discussion review. Written. Here's the one. Oh, verbal. Okay, I'm not being very clear. Interprofessional. Look at those spelling errors. Interprofessional. 5 minutes or more. Well, they are based on time. And these are the 2 written ones. Written report. The other ones are verbal and written. They're going to pay more, but they're going to take more time. Opioid treatment updates, periodic assessment via audio only. Fantastic. But they're saying it all depends on whether or not SAMHSA and the DEA have an idea about that. They're also going to allow people to do the social determinant of health assessment as part of intake activities. That's a G0136, pays about $15. The delaying the in-person visit requirement. It's congressionally mandated. They can't waive it, but they're suggesting a delay of enforcement. Audio only updates. These codes are going away. Telephone's bundled into the other services anyway. But this new definition being proposed, as I mentioned before, will allow audio only, given those caveats that I had mentioned previously. And with that, opened you up to the wide world of like, wow, I need to go back to the Federal Register and read that whole thing on behavioral health. I think download the chat perhaps too. But here's an easy one. Does POS 10 include other non-facility locations like a patient's vehicle or place of employment? Yes. As long as it's not a facility. Don't document that they were in their car. Sounds like not a facility. This was in the moment. What date did that change? How about if the client is in a fire truck with a fox in a box? Yes, that is place of service 10. Let's see. Aetna makes us use modifier 10 and 95. Ugh. I'm sorry, Linda. We have to really jump through hoops. Everyone's got their own ideas. Regents uses GT and 93.
This is Carol. Can I just jump in for a question here? What you were talking about was Medicare billing, and
Yep.
does commercial payers and Medicaid, will they differ in terms of their coding and what they'll pay for and things across states?
Depending on your state laws, being California centric, since I'm in San Francisco, California does have a state law that commercial insurers have to pay for a telehealth service if the service can be done in an office as well. You can do it online. If the patient comes into the office and it can be done online, they need to pay for it. For other states, I do know some other insurance companies have said that they rely on the appendix P and or T in the back of the AMA CPT book, and they are adopting those codes only as to what they'll pay via audio only or audio video. So it depends. Like anything with payers and Medicaid,
Right.
it all depends. Great resources, Center for Connected Health Policy has all the Medicaid caveats about what their policies are, cchpca.org. And then also, if you have access through Availity, you can download the various telehealth policies from the commercial payers, depending on where you sit. I mean, it can change from Northern California to Southern California. So I don't know what to say. Keep a very detailed grid. Put it into your claim edits. CPT codes in the chat. The CPT code URL will be, they're in the slides. And RCRC also has that. And there's the link. Someone already answered that. So that's just about it. I don't think this is a great point that Mark just said. He had a client several days ago that said she didn't want him to see her, and then after a few minutes, she felt okay and allowed him to see her. So that's a really great anecdote to illustrate why someone may not want to be on camera. RTM codes are available for non-respiratory, non-musculoskeletal. None. It's just CBT, respiratory, and MSK now. RPM is for physiological. Okay.
Okay. That sounds fantastic. Really fantastic talk. Thanks so much, Carol. I know you have a lot of expertise, and I appreciate you sharing that with us. All right. Thank you so much, Carol. And thanks, folks, for joining us today. And we look forward to seeing you on September 20th. Have a good weekend, everyone.